All right. You're live.
Okay. So welcome to Module 5. I want to talk a little bit about a couple of items in hemorrhage management on the horizon. The two that I'm going to talk about are fibrinogen and transacetic acid. So fibrinogen, as you know, is a component of blood that is needed for it to clot effectively. And unfortunately, major hemorrhage, obstetric hemorrhage, often depletes the coagulation factors and specifically this fibrinogen. We do know that low fibrinogen in patients is associated with this further increase in blood loss and also a greater need for transfusion in general. So currently, the way we get fibrinogen to patients who've been hemorrhaging is through cryoprecipitate. It's favored over fresh frozen plasma because although fresh frozen plasma has fibrinogen in it, it's about 4.5 times higher in fibrinogen content, meaning the cryoprecipitate is. And each unit of cryoprecipitate contains approximately 200 to 250 milligrams per unit. There is a fibrinogen concentrate, which is available for purchase that can be used for rapid restoration of fibrinogen levels without tapping into the blood supply for that facility. It can be given in a small volume compared to even cryoprecipitate, and therefore you can decrease the chance of volume overload during these major hemorrhages. So where are we at in the evidence for use of fibrinogen concentrate? Well, we need to think a little bit about what happens with fibrinogen in pregnancy. So we just have some numbers here from a variety of studies. So you can see the non-pregnant levels ranging somewhere around 3 for fibrinogen, and you see this steady increase going all the way up to somewhere around 5 grams per liter of fibrinogen concentrate in maternal blood by the time you reach the 3rd trimester. Okay. There was a prospective study done that was published in 2007, so about 10 years ago. It had a little over 120 women, and 50 of them ended up with severe postpartum hemorrhage. What they did, the way we defined severe hemorrhage was greater than 4 units of PAC cells were needed, or their hemoglobin dropped by greater than 4 points, or need for surgical intervention or mortality. And what was done was, as soon as a patient was beginning to be concerning for hemorrhage, at that point, before any blood products had been administered, they drew a lab and looked at the fibrinogen level. And what you see from this data is the patients that started out into their hemorrhage with the lower fibrinogen level had a much greater risk of getting into a severe postpartum hemorrhage. So it made people wonder if just giving fibrinogen early on might benefit the patient, given this association. So there was another study done that was published in 2015 that looked at treatment of hemorrhaging patients with 2 grams of fibrinogen at the onset of the hemorrhage. So there were 2 groups, and once the hemorrhage started, one group, they went with the standard care, and the other group got an immediate 2 grams of fibrinogen concentrate. Unfortunately, they saw no difference in the overall outcome by any measure other than the actual, you see a slight increase there, even though it's not statistically significant, of the fibrinogen level. But even that really didn't change, let alone maternal outcomes. And so from this study, it would make us wonder if at least giving fibrinogen at this stage is of any benefit. So we have another study, 2015 again, and this is what's known as a prospective 2-phase study. What happened at this institution was they had just instituted an obstetric hemorrhage care pathway, and they performed it for about 12 months, and they looked at their outcomes, looked at the data, and also looked at the fibrinogen level, and that averaged around 3 grams for those patients during their care. And then at the end of that year, they decided to implement a new component to their care pathway, and that was administering fibrinogen concentrate to patients who were having a significant postpartum hemorrhage, right? And the way they determined that, I should say, is they used testing to look at coagulation factors. And if the testing showed that the fibrinogen was low, less than 2 grams per liter, that's when they would administer the fibrinogen concentrate. So things they noticed were that after implementation of this other component of using fibrinogen concentrate to their hemorrhage protocol, they decreased their average blood product use from 8 units to 3 units per patient that would have been in the first phase of the study. So they showed a potential benefit, at least in need for transfusion, with guided fibrinogen administration. So that brings us to transaxamic acid. So transaxamic acid actually inhibits the breakdown of clot. It's an inhibitor of fibrinolysis, and it's felt to potentially reduce bleeding in the setting of coagulation abnormalities. It's been studied for many years in trauma and in other surgeries, and only recently, here earlier this year, 2017, was a multi-centered, huge study of over 20,000 women who had postpartum hemorrhage completed. And it was a great study. It included both low and high resource countries. What the trial demonstrated was a decrease in mortality of basically a third when 1 gram of transaxamic acid was administered within 3 hours of diagnosing a postpartum hemorrhage. So the way the transaxamic acid is administered is it's given intravenously. That gram is given over a period of time of around 10 minutes. If at 30 minutes the bleeding has not improved, a second gram was given. I think most importantly is because there were rather 20,000 women in the trial, they were able to look at safety issues like thromboembolic events, seizures, kidney complications, and they noticed that whether or not the woman was in the group that got the transaxamic acid or the group that did not, there were not any higher rates of these more rare events in either group. So it sort of speaks to the potential safety of the drug. There's a little bit of a debate about, when it should be administered, when it would be most effective. Should it be used in all cases of significant postpartum hemorrhage? Is it specific to just certain resources? Meaning if you have a high level of resources available, do you still need it? So all these need to be decided in the future. It is felt, though, if you are going to use it, that it's probably best to administer it before you give the fibrinogen so that it can help those fibrinogen sources such as cryoprecipitate or fresh frozen plasma from breaking down. However, don't delay your standard treatment and if you're waiting to get this medication. It's most effective from the data in this study if it's given within 3 hours of diagnosing the hemorrhage. I think it's also important to note that in the World Health Organization's 2012 guidelines, they don't support the use of transaxamic acid for the initial phases of postpartum hemorrhage treatment. They recommend transaxamic acid if the oxytocin and other uterotonics fail to stop the bleeding, or if the bleeding is felt to be due to trauma, where we have other literature supporting the use of transaxamic acid. The World Health Organization, again, is updating its guidelines, hopefully any day soon, where they're going to put out the new version sometime in 2017. And I would expect, since that large trial has been completed, they will update their statement more specifically about the use of transaxamic acid. So please look for that also. Thanks. Thanks.